Dr. Lipov, you're also treating PTSD.
Thank you very much. Yes, and I've had, I think, some interesting results I'd like to talk to the committee about. Thank you very much for having me here. It's very illustrious people at the table with big institutions. Unfortunately, I'm not part of any big institution, but I'd like to tell you what I've done so far and what I've accomplished and what I'd like to achieve. Basically, my approach is I'm a pain physician. So CRPS, NTU talked about, I wrote actually and presented articles in the Netherlands about. There is a procedure called Stellate Ganglion Blockade. It has been around since 1925. My father was born in 1925. I've personally been doing successfully that procedure for the last 22 years. I've never had any complications. Through an interesting events, I have figured out it seems to work for PTS. And let me just give you one example of a soldier I treated, and you'll get a feel for it. The first soldier I treated was a special service gentleman. He was a sergeant in Iraq. He was in a helicopter, crashed twice. He was brought down twice by unfriendly fire. He was knocked out over 30 minutes both times. Then he was patrolling the street in Iraq, and a child laden with explosives was coming at him, and he shot the child with anticipated consequences. He got a severe PTSD from it, or PTS, sorry. And then he was at home, and then he woke up twice choking his wife. The second time, the wife said, basically, you either leave or get treated now. His boss happened to know me. He sent him to me. We did an injection. In 30 minutes after the procedure, most of his PTS symptoms went away. We also did some functional MRI information on this gentleman, which I'll touch on in a second. But that was published in the newspaper. I wrote an article about it, but it was published in the newspaper, and Dr. Mulvaney from Walter Reed Hospital read that article. He called me up. He said, is that real, or is that this sounds too good to be true? And I said, it's totally real. Let me tell you what, how, all the details. And he repeated that, and that came out in Pain Practitioner in April of this year. So Dr. Mulvaney presented, he was supposed to be here. Actually, you as chairman has invited him, but Dr. Mulvaney is actually taking care of soldiers currently, so he wasn't able to make it. So my first publication regarding this came out in 2008. I have asked for DoD funding in 2007, and I was rejected of that. I asked again for funding in 2009. I was rejected. Primarily, I was rejected based on, they said, if this is really true, this will change medicine as we know it. However, you have no idea how it works, so it's not possible for it to work. So I thought the logic was fascinating, but the way I think to do it is to address it. So I wrote an article called Unified Theory of Stellate Ganglion Block. And that came out. I have a copy of that with me, of those interested in it. But essentially, that article summarizes some very interesting things that we have seen and published on. And then Stellate Ganglion Block has now been shown by me to be effective in hot flashes, for example. That's how I started all this exploration of Stellate Ganglion Block in some unique applications. That came out in 2005. I had a lot of criticism. People said, it's not possible. You don't know how it works, so forget about that. Then I published an article in Lancet Oncology, which is a major medical journal. I was invited to perform those blocks in the Netherlands, in Norway. And then, since then, it's been replicated for hot flashes. In Belgium team replicated it, as well as a Mayo team replicated that. So Stellate Ganglion Block is now being very accurately looked at major institutions for hot flashes and psychiatric issues during menopause. But interestingly enough, for PTSD, it has been very effective. It works very rapidly. We can talk about the side effects. One of the questions Mr. Byer is going to ask is that FDA approved. I have a letter from FDA saying it is perfectly appropriate for me to use it. So I do have FDA clearance. Thus, I'm currently running, since I was not able to get funding, and I think it's a very important thing to do. I personally am sponsoring studies through my office. It's an IRB-approved, single-blind placebo study to demonstrate efficacy of that. I have had a very difficult time recruiting soldiers, even if I'm paying for that, which makes it interesting. One part of the reason I asked about the morphine study, I was very interested in that when I read that. as an anesthesiologist, I've done anesthetics, of course. That's what I did originally before I got into pain medicine. If you look at the mechanism, why all of this happens, there is one molecule that's extremely important, NGF, nerve growth factor. The neurosurgery people should know all that. Usually, when there is a nerve injury, NGF goes up or increases. There was a study done on soldiers in Australia. If a soldier is about to jump out of the airplane, they found NGF doubles at that time. If estrogen decreases, NGF increases as well. If NGF is increased in the brain, it gets carried back to the stellate ganglion, which is in the neck, and it produces something called sprouting of the nerves. It looks like little new flowers sprouting. Those flowers produce a transmitter called norepinephrine or adrenaline, which most people have heard about, and makes people very anxious, gives them PTSD symptoms, things like that. When you put local anesthetic onto the nerve, that sprouting dies off and goes back to normal. So the block, the reason it works so fast, it numbs it up very quickly. And Jason, the gentleman I was talking about, had 2 injections so far. It's been 2.5 years under my treatment. First one lasted 4 months. Then he saw fireworks, a known trigger for PTSD. Half of his symptoms came back. He came back, had 1 more injection. Right now, he is off all drugs. He's gainfully employed as a chemist. He's still with the same woman that he was married to before. Dr. Mulvaney's patients, he had 2 of them. Both are off all drugs currently, and their functions markedly improved. The last piece of the equation is the morphine. If you look at that, it reduces NGF. So I think the mechanism of the memory function change is NGF. The last thing I'd like to bring up is, again, I've suffered through a few critical moments because it's so odd, and I understand why it would seem odd. But if you look at the history of stellate ganglion block, in 1947 in Cleveland Clinic, there was a report of successful use of stellate ganglion block for depression. In 1993, post-climateric psychosis was used. 1955, there was an effect described. In 2002, there was a positive effect of stellate ganglion block on schizophrenia. Thus, the stellate ganglion block has occasional reports over the years of psychiatric effects. And the great thing about it, one of the things that you've talked about is innovation and immediacy. Can it be applied tomorrow? Stellate ganglion block, or at least the way I've modified it to make it a little safer, can be applied correctly very rapidly. There is no FDA clearance required. There is only minor training or retraining of pain physicians required, and that could be available very rapidly. The other question is, Mr. Teagues asked, he talked about invisible wounds. One of the things that was talked about here is diagnosis. First you have to have diagnosis, then you have treatment. As you can see, all the clinicians here talk about diagnosis first. I have a functional MRI information on this on my soldier. So what you can do is, basically, there was a study done, again, in Australia for some reason. They showed some nasty pictures to soldiers. They did a functional MRI, which is basically an MRI that lights up when certain parts of the brain are activated. So they took people who had severe PTSD, and they did a functional MRI by showing bad pictures, and it changed the brain. They could see it. They treated those guys for a year. They repeated the same process. And they found the people who were non-responders had the same looking MRI. The people who were responders had a deactivation of amygdala. Jason had deactivation of amygdala in 2 days after the block, demonstrated an objective finding. So one of my suggestions is to make a diagnosis. It would be very helpful to know who has PTS, and then a treatment associated with it would be helpful. That's all I have. Thank you.